they're getting. And so that's really helped address some of the challenges we've had with staffing and things like that. And we did that in coordination with our first responder partners as well. Went through that whole pilot program for a year, and just in February it was approved by our board. Skip over that slide.
Does that relate to the smaller units?
He's so long.
Sorry, what was the question?
Yes, the different types of tech, does that relate to the smaller units? It looks like you're using either pickups or Suburbans to run some of your calls. Can you comment on that?
So what we did with the program, but it wasn't necessarily part of the pilot program, we increased the number of, we have full-time supervisors and part-time supervisors. The part-time supervisors have historically been on ambulances, and as we've been able to increase staffing, we've taken some of those part-time supervisors and put them in those pickup trucks that you're seeing running around. And they have the ability to go out with these EMT ambulances on some calls that they may need to be upgraded or whatever. Those are metrics that we watch, and it's very low numbers, but it also gives us the opportunity to have more face time with the crews and things like that, because we do engagement surveys every other year. And that's one of the things that we heard when we were just running 2 or 3 supervisors. It was like, I only hear from my supervisor when I'm in trouble. So this gives them a little bit more opportunity to interface with the crews and a little bit more seasoned provider that can run on some of the more critical calls or handle the lower acuity calls.
Okay, so those vehicles really aren't treating patients or are not instead of an ambulance?
They are not sent instead of an ambulance, no, sir. We do, no, they are not. We do have some program patients that we'll talk about with our MIH. We affectionately call them high utilizers because in some of the more extreme cases, they'll call like once a day or more. And we'll enroll them in our HUG program, and they will call 911, they will get an ambulance response, but they will also get a critical care paramedic response or mobile integrated health response, and they'll go out and see these patients and go, okay, well, what's going on today? And the big goal with that is really, typically these people have social drivers that make them call 911 more often. And so we really try to identify those and give those folks what they need. The next slide, our ET3 program, it's a Medicare program. It's a pilot program, although we can't call it a pilot program because there's some federal regulations around what a pilot program is.
It's not a pilot program.
That's right, it's not a pilot program. So it's a 5-year trial period, and so basically what that is we take these low acuity complaints, we do send an ambulance out to them, and we can offer these patients telemedicine. So they have the opportunity to talk with a physician. Again, we've gotten really positive feedback on this overall, and it's things like prescription refills. And we had one lady that got discharged from the hospital with she had an abdominal issue, and part of her discharge instructions were, hey, be on a clear liquid diet, follow up with your primary care physician. She went home and ate dinner. So we did the telehealth thing, and the doctor said, did they talk to you about clear liquids? And she goes, I don't remember that. And they said, well, that's what's causing your nausea and vomiting. We can give you some medicine for that, give you some fluid, and leave you here, or they can take you back to the emergency room. She said, I'd much rather stay at home and see how that works. And we treated her at home, and she stayed there, and she was very happy with that. So we're excited about that opportunity because there are a lot of cases like that. People use 911 to help access the healthcare system. And a lot of times because they don't know how or because they're scared or whatever, it provides us the opportunity to intervene and say, hey, this may be a more appropriate level of care for you. So I mentioned we went in network with Aetna. Aetna sees the value in this, and they contracted with us. They're actually part of our contract with them is they pay us the same amount as if we had transported the patient to the hospital for treating that patient on scene. The savings for the insurance companies is the average ER bill is $1,500 to $2,500, and so they save that on every one of those low acuity patients that don't really need to be there. So, and Medicaid's going to enter into a very similar program starting on September 1st. And so that's a pretty good percentage of our total call volume that we'll see through that. That's actually where I was just prior to this, and interestingly enough, one of our field training officers who I was talking to about this, he spoke up and he said, hey, that he was running a call in River Oaks, and he got out of the ambulance, and the firefighter was like, hey, I think this patient can do that ET3 thing. And so they're really engaged with it and excited about it. So, which is a good thing. Last year we saw over 500 patients. We do about 170,000 calls a year, so 500 isn't a tremendous amount. We'd like to see that increase a little bit. But out of that 500, 77% of them stayed at home. So, some of the fun stuff, we got a new ambulance this year. It's an ambulance bus. We'll deploy this. It's in partnership with the Regional Advisory Council, so they actually give us this bus. They sign the title over to us. We insure it. We take care of the maintenance, and then we staff it when they want to deploy. So the old one we had went down on the coast, and we had hurricanes and things like that. This one will do the same thing. We actually deployed the last one out to the I-35 pileup. They aren't great for acute, like really bad patients because you really need one-to-one care, but it works really well for a warming center and to give us somewhere warm to help triage people and kind of get them out of the mess. We also use it to evacuate one of the nursing homes because it'll hold 17 patients laying down. So during the COVID incidents, one of the nursing homes was evacuated. The downside of that is by the time you get about number 14 on the bus, number 1 has to go to the restroom. So, so it does take a little bit longer, but we did a little vehicle redesign this year also. That pickup truck in the top right corner, I think, is what they were referring to on the phone that they may see out running around. We have that, and we have Tahoes that our supervisors and critical care paramedics are in. Historically, they've been white. There is a microchip shortage. I could not find four pickup trucks that were white, so we got gray, and everybody kind of likes how they look, so we'll probably have gray supervisor vehicles from here on out. But and we also changed the check marks on the side, the conspicuity, to be that bright yellow. Because we've actually had a fair amount of people run into our ambulances and supervisor vehicles, so hopefully it stands out a little bit more. They're less likely to run into them. Our mobile integrated healthcare we've been doing since 2009. I mentioned our high utilizer program. We partner with hospice and several different agencies to help people stay at home and get the care they need in their home rather than having to go back in the hospital. It's very comforting for families and whatnot that their loved ones are enrolled in hospice. It gives them that opportunity to spend with them in that home instead of necessarily having to go through all the challenges of being in the hospital. So, and there are 90 River Oaks residents that are part of one of those programs, not necessarily hospice, but the high utilizer program or home health programs that we work through. Some of the stuff that we're going to be looking at through the next year is our lights and sirens usage. There was a joint statement written by 14 different agencies from fire department, EMS, physicians groups. These folks can normally not agree on what color the sky is, so the fact that 14 of them were willing to sign off on this is a pretty big deal. And basically it really focuses on treating lights and sirens like a medication intervention. When do we actually need to have it? Because a small percentage, like 10 to 12% of our total calls are actually time-sensitive emergencies. There may be another 10 or 15% that are kind of in that gray area. We utilize lights and sirens a lot. Over the last 2 years, we've had 11 crew members that have been injured in motor vehicle accidents, and all 11 of them were utilizing lights and sirens at the time. And so we really want to dive into that, and essentially what we do with that is we take a look at the last 3 years worth of data and say, okay, well, based on all these 300 EMD codes that I was describing, the reason you're asked all the questions when you call 911, of these, how many people were actually having life-threatening emergencies, and we kind of prioritize them by that. So, you know, the ones where people are having heart attacks, they aren't breathing, their heart stops, that kind of stuff, we're going lights and sirens to, but the stubbed toes and the leg pains and the things that they can wait a few minutes longer aren't really going to matter. The lights and sirens, on average, they save about 45 seconds to a minute and a half overall. And the big things the science is pointing to is when your heart, when your heart stops, the bigger deals are getting somebody to start CPR. And so we will actually walk people through how to do that with their loved one when they call 911, because after 4 minutes, people start losing brain cells. And nobody can get there that fast, typically. So
When you have your lights and sirens on, you can only run about 10 miles an hour.
Yes. And then we have to stop at every traffic light.